Good morning, good afternoon. Welcome to the UNICEF-WHO joint webinar using the LiST tool to model the indirect impact of COVID-19 on maternal and child deaths. So I'm Dan Zheng, Senior Advisor, Statistics and Monitoring in UNICEF. I'm also the coordinator of the UN Interagency Group for Child Mortality Estimation. So this is a joint webinar of UNICEF and WHO. Teresa, could you please introduce yourself? Teresa is going to moderate together with me.
Hello, welcome everybody. Good morning or good afternoon, depending upon where you're coming from. My name is Dr. Teresa Diaz. I am the Unit Chief for Epidemiology and Monitoring and Evaluation for the Maternal, Newborn, Child, Adolescent Health and Aging Department in the World Health Organization. And we have now just started to begun to work with the UNICEF on monitoring and evaluation of disruption of services related to disruptive essential services related to COVID. And this is one of the streams, which is a stream I'm modeling. Thank you.
Thank you, Teresa. So today we invite scientists and researchers from Johns Hopkins Bloomberg School of Public Health to present the LiST tool and their recent paper. And the paper is about the scenario-based projections on the impact of disruption in health services and due to COVID-19 on maternal and the child. And today we are pleased to have Tim Robertson, Emily Carter, and Neff Walker with us to present the models and the findings. Tim, Emily, and Neff, could you maybe show your screen, show your video just for a minute for now, and to say hi with participants?
Hello, Emily Carter.
Hi, Emily.
And Neff Walker.
Hi, Neff.
Hi, Ron. It's Tim Robertson here.
Hi, Tim. Yeah, thank you for colleagues from JHU joining us and present the LiST tool and their recent paper and the findings. And today we will also have colleagues from UNICEF-WHO, Lucia Hook and David Sherrill to talk about the dashboard containing country specific results and the explanatory notes that we put together. And Teresa is going to discuss with us as well the next steps, etc. So before I hand over to Emily, Teresa, do you have anything to add in the opening?
No, let's proceed.
Okay, great. So today we hope we have this platform for all of you, to have a chance to discuss with the co-authors of the LiST paper. We will have some opportunity to also discuss how to interpret and use the findings and the country-specific results. So let's start with Emily. Emily, over to you.
Great, thank you so much. Hi, I'm Emily Carter. As Donza mentioned, I'm an scientist in the International Health Department at Johns Hopkins School of Public Health of the COVID-19 countries. This work was led by Tim, and the project PI is Neff Walker, who's also on the
Emily? Emily, are you there?
I believe that she's frozen. This happened before last time.
Right.
Tim or Neff, do either of you want to take over the presentation?
Okay, can you hear me okay, Teresa, Dungeon?
Yes.
Yes.
Okay, I'll take over temporarily. If Emily comes back, then she can. Okay, so hi everyone. As Emily, I think was saying, we're a team from Johns Hopkins University. Today, myself, Emily, and Neff are going to be talking or answering questions. We are part of a team at Johns Hopkins that has developed in the past and continues to maintain the LiST tool. And we'll talk a little bit about that as we go on today. The purpose of today, we're going to just give you some idea of our motivation for our analysis, why we did it. We're going to talk briefly about LiST, how it works. Then we're going to talk about our methods and assumptions for this particular analysis, our results, and then get into some thoughts around what we plan to do in the future and how you yourselves might want to run your own LiST analysis or think about kind of similar models for understanding the indirect effects going forward through this year as the pandemic unfolds. So I imagine most of you have seen this paper. This is the paper that we're talking about here, the analysis that we're talking about. I'm not going to talk too much about the results in this presentation. So if you are interested in diving a little deeper into some of the results or the discussion, then I direct you to this paper, which you can find online. So I think, as everyone knows here, the pandemic has created a state of emergency around the world. And we know from the past that in situations such as these, in outbreaks, our health resources can shift to responding to that emergency, meaning that regular routine health services perhaps go neglected, or for other reasons, people are unable to come to health facilities or don't want to come to health facilities, and therefore utilization of services decreases. So obviously that has been true in the past, and we thought that it may also be true now under the pandemic. And I think a lot of anecdotal evidence is suggesting that that is the case. So even though COVID itself has kind of affects children and women of reproductive age to less degrees than older people or other age categories, these people may be disproportionately affected by the disruption of routine health services. And as I said before, we know from, for example, the Ebola outbreak, that the indirect effects of the outbreak can be more severe, particularly for maternal and child health, than the outbreak itself. Okay, so just to recap again, we see various kind of factors at play here that might be responsible for this reduced access to care. The first would be that the provision of services itself is interrupted. So health resources are reassigned for the pandemic response. There could be issues in the health workforce availability. Either health workers are allocated to respond to the pandemic, or health workers themselves become sick or are unable to get to facilities for whatever reason. Other issues concern the supply chain, medicines not being able to get where they need to be. And under the COVID pandemic, campaigns being paused or reduced because of concerns for social distancing and that kind of thing.
Hey, Tim, I'm back on if you would like me to continue.
Imagine that there will be reduced service utilization. So for example, movement restrictions, other control measures, lockdowns, preventing or disinclining people from seeking care at facilities, creating reduced demand for services. Also, perhaps secondary effects, the lockdown leading to kind of economic deterioration, people's incomes kind of are lower, and that then might bring about financial barriers for people to access care. I'll just finish this slide and then let Emily take over again. So in addition to those health system factors, interrupted service provision and reduced utilization, for this analysis and in our discussions with stakeholders globally, we thought it would be important to consider increased wasting due to increased food insecurity, or reduced food security. So the World Food Programme, as I'm sure many of you have seen, are suggesting that food insecurity might spike, many more children not being able to get sufficient macronutrient intake. And we thought that's important to capture here because obviously an increase in wasting will have an impact on mortality. So this is largely outside of the health sector, but nonetheless a health issue because it increases risk of dying for other infectious diseases. So, okay, Emily, if you're there, you want to take it?
Great. Can you hear me?
Yes.
Great, fabulous. So with these concerns in mind, we set out to assess if certain hypothetical COVID-19 outbreak and response scenarios would occur, what would be the indirect impact on maternal and child mortality. So we explored 3 scenarios of varying severity over 3 windows of immediate impact, 3, 6, and 12 months. And we used data from 118 low and middle income countries that account for over 97% of global maternal and child mortality. So we conducted the analysis using the LiST tool, which can model the mortality impact related to change in over 70 RMNCH interventions or risk factors. And our ultimate objective was to generate realistic, quantifiable estimates as a reference point for decision makers currently weighing response strategies. So we've been engaged with colleagues at WHO, UNICEF, the World Bank, and the Bill and Melinda Gates Foundation since early in the project. And we really consider this our first phase of work. And Tim will speak to some of our future plans later in the presentation. Next slide. So I just wanted to give a quick kind of introduction to the LiST tool. So LiST is a linear deterministic mathematical causal model used to estimate mortality impact based on a change in coverage of interventions and prevalence of risk factors. The tool is housed within the Spectrum computer software. So it's based around a demographic projection tied to trends in mortality and fertility. And the tool has been validated in numerous settings. The tool was developed by the Institute for, the LiST tool team at the Institute for International Programs with collaborators from numerous institutions. And you can see here on the right-hand side, this is just kind of an overview of the relationships between interventions, risk factors, and mortality within the tool itself. And each of these boxes actually contains numerous interventions. Next slide. And this is actually just a quick snapshot of some of the interventions impacting on child mortality within the tool. And this is meant just to highlight the complexity of the relationships within the model. Next slide. So how does the LiST analysis actually run? So you start by creating a baseline projection for a country or region. And this is essentially your known health status for the country in a given year. And that baseline projection is based on demographic structure for a country, and we pulled that from the World Population Prospectus. And for child mortality, we pull our mortality rates from IGMI and partition deaths by cause using MICI data. And then we input levels of intervention coverage and risk factors based primarily on data from population-based household surveys or joint WHO-UNICEF estimates. And then that helps us to create together an envelope of deaths by cause for the established intervention coverage levels. So that really creates a potential for the lives lost or saved that can be attributable to the change in coverage of an intervention or risk factor. And from that baseline, we can either scale coverage up or down. In this analysis, again, we looked at a reduction in coverage of numerous interventions and an increase in the prevalence of wasting. And so then we recompute our mortality by cause. Next slide. So we take that change in intervention coverage, tempered by the effectiveness of the intervention in averting mortality, and apply that to the baseline envelope of potentially preventable deaths. And we apply that change in coverage for each intervention along the continuum of care. Next slide. And then ultimately we can compare that those estimates against a counterfactual. So typically this would be a model in which there's no change in coverage, or sometimes it's one using historical trends. And so we can take that difference in model deaths to show the impact of our change in specific intervention coverages or risk factors. Next. I'm going to now hand over to Tim, who's going to take us through the methods for this analysis.
Okay, thanks, Emily. In this next section, I'm going to walk through some of the logic that we use to create our assumptions and set up our models for this analysis. So what you see here represents our thinking for how disruptions due to the pandemic on the left will lead to increases in maternal and child mortality on the right. And if you've read the paper, you'll see that there's a kind of smaller version of this model or a subset of this in the paper itself. Broadly speaking, we think about two kind of overarching pathways by which the pandemic will disrupt maternal and child mortality. So going from left to right, on the top, you see that the pandemic, we imagine, will affect the availability of health workers, the availability of supplies and equipment, and demand and access to health services. So we think about those as our kind of, as four health systems components. And we imagine that they might be disrupted, leading to reduced provision and utilization of health services, as we talked about before, leading to reduced coverage of health interventions, and then that leads to increased maternal and child mortality. And we see a second path along the bottom, which is this pathway largely outside of the health system by which wasting is increased. So we're imagining that the pandemic will increase or disrupt factors affecting undernutrition. So for example, health incomes, food systems, social safety nets, that we imagine will lead to a rise in the prevalence of wasting, and that in turn will also increase maternal and child mortality. Wasting largely doesn't sort of kill kids itself, but rather increases the risk that a child might die from infectious diseases. So I want to come back and unpack those two broad pathways in a minute.
Hey, 宝贝儿，妈来看。
Hello. Okay. So before I look at those two kind of pathways, I first want to sort of draw your attention to the right-hand side of the model here. So you see here, this specific part of the model, what I think of as the downstream or the kind of far right portion of our model. This is what we can model in LiST, in the LiveSave tool. So we can take changes in the coverage of health interventions, and we can show how those changes in coverage of health interventions, so for us, a reduced coverage in health interventions will lead to increased maternal and child mortality. And the same for wasting. We can show that wasting will increase risk of death from other factors, thus leading to increased maternal and child mortality. So this section on the right, this is what LiST is all about. And if you're familiar with LiST, you will be familiar with this kind of concept and this very simple framework. What you see here, further back upstream, this is what we think of as our assumptions for this analysis, or our kind of scenarios. So these are things that obviously will have an effect further downstream on coverage, wasting, and maternal and child mortality. But they're things for which we don't have a really strong model, or at least that are not modeled as part of LiST. So these boxes, what you see here, for us in our analysis, this is where we came up with our hypothetical scenarios. We put numbers around the reduction in the availability of health workers, supplies, and equipment, and we created a calculation to show how those things then would reduce overall coverage of interventions. But all of that is our kind of scenarios and our assumptions. Then after we developed those assumptions, we took them into LiST and used LiST to model change in maternal and child mortality based on change in coverage and wasting. Okay, so this, again, this top path, this is the bit that you might have seen from the paper. For us, what we did is we chose these four health systems components and used a very simple multiplicative model and just said, you know, that the reduction of all of these things would combine together to give an overall reduction in health intervention. So our model here is very simple. And in fact, we didn't include any interactions between components. It was just one simple kind of multiplicative model. The reason we did that is because, you know, we could arguably have just said, well, we expect that coverage will reduce by 20% or coverage will reduce by something. I think by opening it up and breaking it apart into health system components, our goal was really to show that, you know, a reduction in any one of these things will contribute to reduced coverage, but also that even if you have a few smaller reductions across all of these components, it could combine to give more of a moderate or large reduction in coverage. So some of the reductions in coverage that we have in the paper at first glance may seem unrealistic, but then when you think about how that could come about easily through smaller reductions in components, I think that makes some of our assumptions a little more justified. When we say reduced coverage of health interventions, we've lumped everything together. This actually represents, upwards of 70 different maternal and child health interventions. And we categorized them into different categories and slightly adjusted the assumptions differently for each of these categories. So what we included in the model were interventions related to family planning, antenatal care, childbirth care, postnatal care, vaccinations, although we attenuated the impact of those vaccinations, and then early childhood preventative and curative, and wasting. I think some people have asked, did we include everything? What did we not include? Well, just briefly, we did not include any changes for breastfeeding, WASH, or HIV. And the reason for that, for breastfeeding and WASH, is that we thought that there would actually be minimal disruption to breastfeeding and WASH. Some have argued that that's not the case, and in fact, we should be considering that these things will change. And we're open to those, and in future analysis, we can take those into consideration. But we didn't include those in our initial model. For HIV, the reason we didn't include it was just because it's the kind of pathways for prevention and treatment of HIV are just much more complex. And also, only a few countries really have a substantial kind of burden of disease from HIV for kids. So we left that out of the model just for this initial analysis. One other thing that people have asked is, and we can clarify here, is that because of the reduction in contraception, due to reduced contraceptive arrangement, because people may not have access to family planning contraception, you could imagine that there would be more kids being born, and therefore, because there are more kids being born, more kids are susceptible to dying. We did not consider that in the model. We just assumed that population would stay constant, given the time periods we were interested in. And as we say in the paper, we didn't include any changes for stunting, just because stunting takes a while itself to be effective. And for our analysis, we were concerned mostly with those kind of short time periods, so we didn't include that in the model. Okay, so that was the first top pathway. And then we have this second pathway, which is the kind of effect of increased wasting. I think there's strong evidence that there are a lot of broader factors that then increase wasting. Unfortunately, there's no great model that we had access to use to kind of model factors and then model the effect on wasting. So for our analysis, we simply chose assumptions for the increase in wasting itself. So while we sort of imagine that this is how it will work, what you're seeing on the screen, we imagine that there will be factors that then in turn increase wasting. For our analysis, we just chose assumptions for the increased prevalence of wasting. Now in LiST, some of you may be familiar, there are two ways in which you can model the kind of impact of wasting, or wasting itself being changed. The first option that you have is to put in a baseline wasting, and then what you do is you put in changes in coverage of interventions that affect wasting. So that would be SAM, MAM, and complementary feeding. So what we could have done is say that because of the pandemic, SAM and MAM, coverage of SAM, MAM is going to reduce, and because of that, you'll see an increase in wasting and then an increase in child and maternal mortality. That, we imagine that will happen, but in LiST, you can either do that or you can do the second option, and we chose the second option. And the second option is just to enter changes in wasting directly. So we say that, at baseline, there will be kind of globally a 10% wasting, or we did it country specific, but there's a certain value or proportion of kids who are wasted. And then we say that that will increase to another proportion. Right? And so that's what we did for our analysis. And so we said for our three scenarios that wasting would increase by 10%, by 20%, and by 50%. The final thing to say is that while I think we stand by this, we recognize that in reality, the pathways here are much more complex, and that I think in future analyses, future models, we could do more to maybe unpack the interactions between these things, consider things in more detail, go further upstream, etc. So just want to put that disclaimer there. Okay, when we then came to start to think about, okay, what numbers are we putting in? We set up 3 scenarios, and the 3 scenarios were of varying severity. So we had scenario 1 being our least severe and scenario 3 being our most severe. And so for all of these scenarios, we put in a reduction at the component level. So for a reduction to workforce availability, supplies, demand, and access. And we did it by intervention category. Now, each of these categories actually represents a number of individual interventions that we put into LiST, but we just sort of put our assumptions at the category level to make things simpler and easier. Excuse me. In our first scenario, we assumed that there would be a sort of global disruption to both the demand and supply side of the health system. So that's why for scenario 1, you see a lot of small reductions everywhere. We did sort of try to be a little bit more discerning with things that might actually not change. So for example, for interventions where perhaps you don't need a skilled health provider. So for example, purchasing contraceptives or purchasing ORS at a local deli or clinic or something, there are certain interventions where the reduction in workforce is perhaps not as relevant. So we sort of attenuated the reduction to those. And on the demand side, we imagine that some interventions are going to be less susceptible to people sort of thinking, oh, well, I may not go there because of the pandemic. Some interventions, people are going to continue to want to go and get that service. Some more than else. And this is entirely speculative, but we thought it would just be interesting to kind of nuance things slightly, although certainly all of this is open for debate. In our second scenario, we imagine that there will be a further reduction on the supply side. So for example, the health system getting constrained, health workers not being able to kind of treat as many people as they wanted to, supply chain disruptions. And then for the third scenario, we imagined even further increases, perhaps further reductions to the workforce, and also big reductions in access, for example, because of movement restrictions or broader lockdown policies or other things like that. So those are our 3 scenarios, and you can see increasing severity. And as I said, for wasting, for each of these scenarios, we said that in scenario 1, we imagine a 10% increase in wasting prevalence, scenario 2, a 20%, and scenario 3, a 50% relative increase in wasting. For those of you familiar with LiST, in order to get all this to happen, we ran 118 countries individually and then aggregated the numbers. Within LiST, there are some tools that enable you to automate the projecting all multiple countries. So we used tools called Scenario Generator and Extract, which you could yourselves learn about and use as well. Because LiST only operates by year, we calculated a 1 year number of additional deaths for 1 year and divided by 12 per month. And then we did some slight kind of modifications to that. In particular, we attenuated the impact of vaccine coverage reductions because of potential protection through herd immunity for shorter periods. Okay, I'm going to just go very briefly through the results because I think if you are, as I said, if you are interested in the results, then I encourage you to read the paper. So this is just a high-level view. So overall, we imagine that because of these disruptions, that we will see an increase in maternal and child deaths, and the more severe the scenario, the greater the number of additional maternal and child deaths. On the left, you have the maternal deaths, and you can see that we expect up to a 38% increase in maternal deaths under our worst scenario, and similarly for children, up to a 44% relative increase in child mortality per month. And we have separated out here the additional deaths due to the reduction in coverage from the reduction due to increase in wasting.
Bị những call mà mẹ.
Helen. Okay, you'll see here that we have the results table here. Again, this is in the paper, and if you want to look at the numbers more closely, I encourage you to go to the paper. Beyond simply presenting kind of aggregate numbers and saying that we expect this many additional deaths, which obviously is important for advocacy and for people to understand that kind of get a reference point for what the kind of costs on kind of in terms of maternal and child health are. Beyond that, there is one further aspect to the analysis that we were able to do, which was to look at the intervention-specific additional deaths. So, for example, in our scenarios, using LiST, we can say that given the reductions to each intervention, given baseline coverage of each intervention, and given the effectiveness of each intervention of reducing risk for certain causes of death, given all of those things, we can say that under our scenarios, each individual intervention will contribute a certain number of additional deaths. So here's our list of interventions for maternal mortality. And at the top, you can see that uterotonics for PPH or others, and antibiotics and anticonvulsants for, say, eclampsia. These three interventions, and maybe with child clean birth environments as well, are going to account for the most for the greatest numbers of additional maternal deaths. So what this is saying is that because of the reductions in our scenarios to these interventions, you are going to see large additional numbers of additional deaths, right? Whereas other interventions, if they were reduced, you will not see as many additional deaths. And there could be many reasons for that. One is that baseline coverage of those interventions may already be low. So further reducing it is not going to have much of an impact. Or it could be that the causes of death on which they operate are not, don't take up a great proportion in certain countries. So therefore, again, reducing them is not going to affect large numbers of deaths. So there are a few different reasons for this. And this table needs to be, I think, interpreted with some care. But in general, we can say that, you know, there are certain interventions, particularly for childbirth for mums, which are going to be, if they were to be reduced, would have more of an impact than others. And we can do that same sort of analysis for kids. And here you can see that wasting and antibiotics and ORS for pneumonia, neonatal sepsis, and diarrhea, those are going to contribute the most for children. Okay. Just briefly, I think I want to emphasize that we recognize that there are a lot of assumptions at play in our analysis, and that the goal wasn't for us to develop numbers or projections or really estimate the future. Our chief goal was just to say, given certain scenarios, what might then be the magnitude of the number of additional maternal and child deaths, just so policymakers could have some sort of reference point for what it would mean if these disruptions were to take place. And I think, as you can agree here, that if disruptions were to take place, we could see significant numbers of additional maternal and child deaths. Another takeaway may be that if health systems do need to prioritize interventions, that certain interventions could be responsible for more deaths if they were to be disrupted. So that is worth taking in mind. And also to think about the fact that some interventions can't be, or the reduction in some interventions can't be mitigated through post-outbreak activities or averted in some other ways. There are health systems, there are health interventions. So for example, in particular, childbirth delivery, where there's just no escaping the need to deliver that intervention at a certain time to everyone who needs it. And another takeaway might be that increase in wasting could have a particularly pronounced impact in terms of additional child deaths. So in our scenarios, child wasting accounted for around 20% of the child mortality. But again, our assumptions around wasting were very speculative. So it may be that wasting increases even further, in which case it would account for even more of the increased child mortality. And obviously wasting is something that operates, it can operate through the health system, and the health system can act on it through ready-to-use therapeutic foods and other strategies. But I think we can all agree that it would take multi-sectoral action requiring governments to strengthen social safety nets and you know, think about food systems and that kind of thing. Okay, I think I've already talked through some of our limitations here. We think of these as hypothetical scenarios. We recognize that there's actual limited empirical data at the moment on what is actually happening. And so we also recognize that these assumptions are based on, for example, what happened in Ebola, what we saw in March and April in high-income countries, and it's still quite early in the pandemic, and we can't really say what's going to happen in other countries, although I think we now, in May, we have some idea. LiST itself has limitations. It has a certain set of interventions that it can model, and but there are other factors outside of LiST which LiST can't model. So, for example, the effect of changes to broader economic systems, lost income, changes to agriculture, etc. And lastly, LiST also, for the vaccine specialists there, LiST does not capture kind of disease dynamics or the effect of potential secondary outbreaks like some other models do that look at kind of disease and vaccination strategies. And yeah, final caveat, our scenarios we modeled for certain time periods, and the deaths that we included for those, the results for those time periods were just the deaths in that period. So I think, again, a more comprehensive analysis would look at kind of lingering additional deaths over time due to kind of effects that have a kind of sustained impact or take a while to return to baseline over the next year or more. Okay, I'll wrap up here in the next couple of minutes. I just want to maybe throw some ideas or give some thought to what we want to do in the future. So again, this initial analysis was just very much a preliminary analysis looking at hypothetical scenarios. I think we see two general paths going forward. One is to refine our scenarios in consultation with experts to kind of update our assumptions in a more robust fashion. So this could include working with countries to get country-specific assumptions, what is, based on what is actually happening in countries. We're working with groups from nutrition, family planning, HIV groups who are doing modeling specific to those interventions, and we want to incorporate some of their assumptions into our kind of broader global LiST model. We could also look at subnational variation and then look in the longer term. The second general way forward we see is to use actual empirical data, so taking real-world data from countries and building that into a model. So instead of running an analysis which says, what if, we can run an analysis that says, well, this is happening or this has happened, and therefore we project that this then will happen in the next few months. So if there's anybody out there who has access to kind of routine data or survey data and is thinking about how they might use that, I think there is certainly a way forward there. And I think Teresa and WHO are organizing a kind of a collection system to bring all that together and move forward on an analysis. Final slide. If you yourself have used LiST in the past, then you'll maybe thinking about whether or not you could use that to do your own models and analysis. And we would absolutely encourage you to do that. I think there is a lot of potential for people in countries to take LiST, to update LiST projection for their country with country-specific assumptions and more data, and build their own country-specific model using LiST. I think we have limited bandwidth, but we are open to helping people do that. If you want to move forward yourself, we encourage you to go to our website, livesafetool.org, and there you can see all of the resources we have there in one place. It's a great website. For those of you who haven't used LiST before, we would say there is some barrier to entry, but not much. So if you're willing to watch a few YouTube videos or read information, I think it's fair to say that you could get started yourself using LiST, even if you've never used it before. We have a growing YouTube page, which has about 20 to 30 different tutorials that walk you through examples of how to use LiST for different things. So that is there for you. And also, if there's anyone there who wants to take what we did for our first analysis and use that as a starting point for your own analysis, then you can do that as well. So we've made all of our projection files, our LiST projection files available at this link. And if you go there, you can download it and then take LiST and run those same projections and then alter certain assumptions around coverage change or other factors. So I think that's it for me. Just to say that we thank all of you for your support. I think WHO and UNICEF came to us early on and have been very supportive throughout this last month as we did this analysis, and hopefully we'll continue our partnership going forward. The LiST itself gets funding from the Gates Foundation and also from Global Affairs Canada, so we're thankful to them as well. So yeah, I think I'll leave it there, and I think we have time for questions. Yeah.
Thank you, Emily and Tim, for this very important work and also share the experience here with us. So, because Emily and the team is going to leave in about 15 minutes for another webinar. We have 15 minutes with them, then Nev Walker will stay with us for more time. And we also, after the 15 minutes Q&A, we are going to talk about the country-specific dashboard and how we can also, like, we put the explanatory note together, so our colleagues will show that, and we will also have more opportunities to ask questions, and Nev will be with us. So I will open the floor, and I think we already collected a few questions through the chat box. You can either raise your hands or type in the chat box to ask questions, or you can jump in if needed to ask questions. So maybe from the chat box, a few questions regarding the assumptions and the underlying data. So I kind of grouped them. One is like how much you really used the previous epidemic, the experience from previous epidemic to inform the assumptions on the reductions in intervention. And the other question regarding the data is that the database used for baseline interventions, where this data come from, and also for some countries whether they don't have recent data, how old the data is, like whether the data for some countries are out of dated for the baseline intervention coverage indicators. And one more question regarding that the LiST tool is more for annual estimates, how reliable it is for short-term estimation work, like 3 months. Yeah, so that's what I collected so far, and my colleagues will also help to raise later.
Okay,
Tim,
great.
Emily.
Yeah, thanks. So I'll take the first question, and then maybe Emily can talk about the data. So the question was, to what extent did we use experiences from past outbreaks? I think the truth is that we did look at all of, well, as much analysis as we could of past outbreaks, but we didn't take any specific numbers from those experiences. Rather, we set up our own assumptions that were kind of loosely informed through our reading of those other things. And then once we had set up our assumptions, we looked at, well, in our scenarios, we've got, say, 15% reductions or 30% reductions or 45% reductions. And we went back to the Ebola experiences and just said, does this somewhat match, is this potentially realistic? And I think a lot of people have pointed out that even our most severe reduction of 45% reductions, 55% reductions, even those sorts of big reductions were in fact seen during the Ebola outbreak. And so therefore, they are within the realm of the plausible. So I think that's how we used it. It was not more specific. We didn't take specific numbers from past outbreaks. Emily?
Right, and so to the point of where the baseline data come from, so the majority of our kind of coverage or risk factor prevalence data come from whatever the most recent population-based household survey is in a country. So the most recent DHS or mixed survey. Some indicators, though, come from WHO, UNICEF joint estimates. For example, the vaccination coverage comes from the UNIC estimates. So most of these surveys most of these data points are penned to a specific survey year, but some of these, the estimates that come from these joint ventures are annual. So in some cases, there are countries where the data may be somewhat out of date, and that is a limitation of the tool. But again, one of the reasons why we would encourage countries to run their own projections, they can input those values themselves if they have more recent or more up-to-date values there.
Okay, great. Doug, was there another question we missed, or was that?
The timing, the year-long estimates for LiST.
Are you able to take that?
Yeah, so LiST does typically produce estimates for year-long periods, but we did take kind of a simplistic approach and just kind of breaking the annual estimates into segments. So it is a very kind of simplistic approach that we took. I think it's reasonable, but as some folks have noted, that's obviously not necessarily how the epidemic will go. You know, there's going to be a scale up, scale down period of impact on coverage. And so there would be opportunities to be more specific, a bit more nuanced in the way that we do those estimates.
Thank you, Tim and Emily. I haven't seen any hand raising, so.
Some people are, this is Teresa. Some people are asking about using HMIS data for doing these projections, if you can answer that.
Yeah, so I think one thing I wanted to make clear, and I think I saw another question around, are we using country-specific baseline? And the answer to that question is yes. So let's take one example, which is the coverage of oral rehydration solution, ORS, in one country, say Nigeria. In our model for example, in our third scenario, we said that coverage of ORS would reduce by 45%, for example. We took Nigeria's baseline coverage ORS number, whatever that was, and I don't have that to hand. Let's say it's 60% or 30%. We took that Nigeria baseline number and then applied the reduction of 45% to that country-specific baseline number. So even though our assumptions were global, the actual data that we used for coverage of interventions and also for cause of death is country-specific as best as possible, taken from the most recent DHS survey or the most recent mix or whatever other source there is. So one good thing about LiST is that we make an effort to keep everything up to date so that we always have the latest coverage numbers, you know, given these big household surveys. And then there's a question around, as Teresa said, using HMIS data. So my way of thinking about it is that, you know, if we can do rigorous analysis of routine data, HMIS system data, to show potential reductions in the number of people coming to facility or the number of people receiving treatment at facility, we have to make sure that we have high quality data, and we also have to have enough time points to see that, okay, that is an actual you know, reduction, and we want to try to iron out any issues in terms of data quality or potential biases in terms of maybe people just aren't reporting at the moment because of COVID, they're not at their desks. If we can iron out all of those issues and say, okay, we are seeing a 20% reduction in HMIS utilization or treatment data, even though that is not a measure of coverage, and even though there is that doesn't have a true denominator, that doesn't capture everyone in the population. If you play it out mathematically, that doesn't quite matter because that is the numerator, and that if you use that to get a change in your numerator, you can then apply that to coverage. So what we imagine doing is using HMIS data to get a reduction in people coming to services, and then applying that to the actual DHS coverage or household best estimate of coverage, applying that reduction to that thing. So I think, going forward, we would see, first of all, making sure we can address all issues of data quality, but then secondly, using both HMIS in conjunction with whatever our best estimate of coverage is.
Just to add to that, we are here for UNICEF and WHO working on a toolkit and guidance of how to use routine HMIS data to monitor disruption of services, including how to look at the quality and how to analyze those data, because you have to figure out how to analyze it. What are you going to compare it to? So we are working on that for the future.
Mm-hmm.
Danson, were there any other questions, or I don't see any other hands up here at all?
Lucia,
Sorry to interrupt.
Lucia is collecting questions. Lucia?
Yeah, I'm trying. Hello, everybody. So I think there was another question where there was a few questions around where the intervention data came from, and they have been answered. And there was also a question on whether it has been consulted with countries to use these coverage indicators. And then there was another question about what to do, and I think Tim, you addressed that earlier, to do in countries that already have low coverage, how to model there. And so maybe I leave these two questions to you, and then there's like two more questions I recorded here.
Okay, I'm afraid I have to leave right now, but the Neff Walker, who is the kind of lead researcher for LifeSave tool, is still on the line, and maybe others from our team who can continue to answer questions.
Yeah, so Lucia, in response to those questions, so we did not consult with any individual countries to verify those coverage data that we were using because they are publicly available and they've been out for a while. We feel that they were reasonable to use, but again, as I mentioned previously, if you're doing this to look at an individual country, it would make sense to go in and use our projection files to ensure that the assumptions that we used align with kind of your best knowledge on the ground. Just part of the reason with our analysis that we publicize the global estimates rather than country-specific estimates. So that is something to keep in mind. What was the second question?
Lucia?
I have to unmute myself. The second question was what to do in countries where the coverage is already low, how to model this outbreak there.
Right, so we just applied a proportional reductions across the board. So what you actually see kind of conversely would be that countries where the initial coverage was high, that percent reduction ends up having a more significant impact than settings where the baseline coverage was already low. So it's in a way already factored into the way that we conducted the analysis. But again, that's something to keep in mind. These were global assumptions about what would happen with the pandemic. But in a setting where you have countries where they have high baseline coverage or low baseline coverage, the way that the pandemic could play out could obviously be different. So it's something to keep in mind when looking at country-specific estimates.
Hi, it's Colin Mathers here. I just wanted to ask you about the modelling of the service impact assumptions. You had four components, like reduction in staffing, reduction in access, and so on. And two of those, I think, were supply side reductions, and the other two were demand side reductions. And then you made a multiplicative assumption, which essentially effectively sort of added up across all four, or multiplied across all four. But if you have a reduction, say, of 10% in supply, whether it's staffing or supplies, and a reduction in demand, they match each other, and there won't be any extra multiplicative reduction in the actual coverage, because 10% reduction in supply and demand will mean a 10% reduction in coverage, because the staffing will still match the demand to the same extent as it did before. And similarly, the reduction in staffing and reduction in supplies, I don't think should be multiplicative either. I mean, there will be second order effects, obviously, and maybe some interactions, but to the first order, the additivity would only, well, I guess the two demand things probably are completely separate and would be additive or multiplicative, but the demand and supply wouldn't? Or am I misunderstanding?
No, I mean, obviously the relationships are fairly complex, and we took a simplistic kind of approach of doing this sort of multiplicative, cumulative in a way, approach to kind of each of these 4 components related to provision and utilization. Yeah, I mean, at the end of the day, we were mostly just concerned with the change in coverage, and we were just trying to look at a slightly more nuanced approach for how to kind of inform those assumptions around the change in coverage. But you're right, there could be different approaches for how to consider kind of the compounding effects of reductions at different stages in the delivery channel. There are obviously, yes, situations where the 2 things would both contribute. In other cases, you know, if you just reduce supplies, then it may not matter if people are coming if the supplies aren't there anyway. So there could obviously be issues that way. I actually also have to jump off. So Neff, it's on you now. Thank you all for your questions.
Thank you, Emily. And
Feel
also
free to reach out if you have any other questions or comments.
Yeah, thank you, Emily. Yeah, so Neff will stay with us.
Yep.
And if there's no urgent questions, then we'll start with Lucia and Dave to talk about the dashboard, which containing the country-specific results from this study, and also the note on this modeling work. Lucia?
Hey, sorry. So I hope you can hear me. I have a little bit poor internet connection currently. So I'm just going to start to share my screen, and please let me know if you can't hear me properly. So just because there were also a couple of questions, and good morning and good afternoon and good evening to everybody. Sorry. So thanks again to Neff and his team for sharing the country results with us, and we have made an effort to put these country results together. Can you see? So here, as you can see here, we have a country dashboard that shows, sorry, here. So if you go on the link here, we have a dashboard that contains all the results for each of the countries, and it contains also the tables with the results. So it makes it easy to look up for each country what are the increases we expect in child deaths or maternal deaths, depending on each scenario. So as you can see here, this is the country dashboard. Here you can select first the UNICEF program region, and then select the country within the region. And then you can select the scenario, and you would see the deaths for under 5, children under 5, and the maternal deaths. And you see also to which intervention these deaths are associated. Here below you see scenario 3, and this is the case of Afghanistan because that is the first country alphabetically. And you see here the change in wasting prevalence is the largest contributor to the deaths in 3 months, 6 months, and 12-month scenario. And similarly, you see for on the right-hand side for maternal deaths, you see here the increases in deaths and also the total deaths, and you see the deaths for each of the interventions. And below, if you scroll down on the dashboard, you also see what is the baseline in the coverage indicator in the country, and what is the modeled decrease in the list scenario based on the scenario you have been selecting. And below, we summarized, as Tim has presented, the reduction applied to each of the interventions, and that is the same across all countries. So this table below would be the same for whatever country you choose. And this analysis has been done for 118 countries, so we can also calculate the regional aggregates for the countries considered in this analysis. This doesn't mean it represents the full region, but it only presents the countries that are included in this analysis, and we can summarize here the number of under 5 deaths and the maternal deaths under each of the scenarios for the 3-month, 6-month, and 12-month period. So this allows you basically to look at what if, and this can be used, and Dave is going to talk about now how we can use this tool for the analysis and for advocacy purposes. Thank you. Over to you, Dave.
Thank you, Lucia. Dave?
Can you stop sharing your screen?
I try. over to you.
Okay, good morning, good afternoon to everyone. I'm Dave Sherrill from UNICEF-WHO with Dunjan and Lucia on child mortality estimation, and I just wanted to briefly cover an explanatory note that we have developed to accompany the dashboard and paper that Lucia and Tim just described, as well as Emily. So I just want to point out first that this explanatory note is available in the country dashboard that Lucia just talked about here in this highlighted portion. And it's also available at data.unicef.org in our Child Survival COVID-19 resource page, which you can see the URL here. So this is just the first page of the explanatory note. Just to point out, we have a brief description of the LiveSave tool here. And as Tim and Emily pointed out, you can get more information about that at livesavetool.org, the link here. We also have a very brief description of the study results. And just to point out, you can link to the study using the explanatory note here as well in the recent study link. So just to point out some of the limitations of these estimates, some cautions as we go forward, and many of these Tim already touched on, so I won't belabor these points, but just to point out that of course these are hypothetical future scenarios based on the assumptions these authors have made, so they're really not intended to be projections or estimates per se. It's important to point out here that the empirical impact on mortality may be quite different. And if countries are successful in minimizing the disruptions to health systems and maintain those services and interventions, the number of additional deaths may be much smaller than what is estimated in that paper. Also to point out another thing that Tim already mentioned, there are a number of other effects that are not considered by this model. So the study considers mortality impact of changes in the intervention coverage and wasting prevalence, but a number of other effects, including from perhaps job and income loss, economic downturns, increased poverty, violence, things like reduced air pollution or less vehicle traffic associated with the pandemic. Those things are not considered and may exacerbate or mitigate the mortality impact to varying degrees. Also important, the study does not report deaths arising from an increase in population size, from increased fertility driven by reduced contraceptive prevalence, although the authors do expect to see those effects in the long term. Despite those limitations, these estimates can be very useful, tell you lots of important things, including, of course, that continued provision of these life-saving interventions and services is critical. You can see from the results of that study that substantial reductions in the intervention coverage can result in very large numbers of additional child or maternal deaths. Important for the individual country context, you can get a sense of the relative importance of various intervention disruptions in the country-specific context, and you can see that in the dashboard tool that Lucia just described, selecting a certain country there, and you can see which of those interventions has the largest impact on the additional deaths here. And of course, the last point is important, that timing is critical. You can see from the results of the paper as well that longer service disruptions will of course result in far more deaths over time. And in addition, those longer restrictions on services or movements may break things like care-seeking patterns, which may be difficult to reinstate. So the timing of these disruptions is very important. Finally, for how to use these estimates, although these results do not convey an exact or even approximate number of additional deaths that could occur, the estimates do serve as a very powerful advocacy tool. First, for raising awareness on the importance, of course, of maintaining these interventions, as well as ensuring continuous investment in these service positions, along with making sure those providers and receivers of services are protected. And relatedly, continuing to encourage women and children to seek these health services with proper protection during the ongoing pandemic. And finally, as we pointed out, we do need to wait to see what the actual empirical impact on service disruptions will be. So we can also use these estimates to advocate for continued monitoring of that intervention coverage during the pandemic in order to act if coverage decreases, since we did see that does have a potentially very large impact on additional child and maternal deaths. So that's it for that review, and any follow-ups on this or other things, you can contact our child mortality team at HQ at childmortality@unicef.org.
Thank you, Lucia and Dave. Before we open the floor for more questions, I'll hand over to Teresa to talk about the next steps.
I'm just opening up my screen to share. Can you see it?
Yes.
So I just wanted to talk about next steps for modeling and maintaining essential services during this pandemic. First of all, what we are doing in regards to models to inform strategies to maintain essential services. WHO is convening 2 modeling consortiums. We have one modeling consortium that is actually specific to the COVID epidemic itself. And then we have a second modeling consortium that relates to this COVID-19 impact on non-COVID-19 essential services and strategies to maintain those services. And these 2 modeling consortium are linked because you need to know about the epidemic itself in order to inform the models that are related to non-COVID essential services. Between WHO, UNICEF, UNFPA, GFF, Momentum, and other partners with support from Bill and Melinda Gates and USAID, we have a modeling task force group to focus on harmonization and facilitating use of integrated SRM and CH and nutrition models. I mean, LiST is one model, but there are several other different models out there, some in sexual reproductive health, and we want to try to bring those together with the other modeling that's taking place. And this is a subarm, I would say, of that modeling group on essential services that I spoke about at WHO. The future work for all these consortiums is to align integrated SMR and NCH and nutrition models with the disease-specific models such as HIV, malaria, immunization, facilitate the use of actual data on disruptions, ensure consistent assumptions and projection parameters, facilitate the development of models to assess best strategies to maintain essential services. So now what you've been seeing are all these models about disruption of services and what could be the impact. But what if we were to kind of flip that a little and say, what can we model of what essential services are being maintained? What could be the potential impact in saving lives? We want to help to facilitate country-specific models, develop any more explanatory technical notes and policy briefs, and provide a platform to access all of these different models. But the most important thing of all is that we want to work toward actually maintaining these essential services, not just modeling the impact of disruptions, but actually maintaining them. So there's several resources that I want to make sure that you're all aware of that are on this slide. First, there's links to resources that are specific for maternal, newborn, child, and adolescent health and aging and sexual reproductive health. And then there are resources on how to maintain community-based healthcare. And there's operational guidance on maintaining essential services that kind of brings everything together. And there will be a new version coming soon. But it's really important to look at these guidances to be able to work with your countries in order to maintain your essential services. Thank you.
Thank you, Teresa. Right. Yeah, so a lot of work is ongoing and still we needed to do much more. And I have seen the chat box already, colleagues indeed had started the discussion regarding the data availability in the disruption of health services, etc., which I think is an important area for our field officers to commit, if possible. This is an area that are really critical for all of the modeling work. If we can have real data, that will help to understand better the real impact. So I will open the floor for any questions, either regarding the LiST paper or modeling work, or the dashboard and the explanatory note that Lucia and Dave showed to us, and apologize for the poor audio. And Lucia already shared the links to download the dashboard and also the explanatory note in the chat box. So if you are interested to take a look, please check the chat box, and we will share the recording and also all the slides, make them available to you as well. So I'll open the floor now. I haven't seen any raised hand. Anybody already put the questions in the chat box, Lucia?
Hi, yes, I'm not sure if you can hear me because my audio is, but there is in the chat box, there's a question about stillbirths, whether they were included in the analysis. And then there's a question on HIV/AIDS services, which I think Tim also touched on earlier. Thank you.
Nev?
Page. Hi. Yes, we did in LiST, everything is recalculated. So we produced estimates of increased stillbirths, but didn't publish it. So if you look at the models, it actually has impact of reduced services on stillbirths. The thing that we don't capture well there that would probably have a bigger impact on stillbirths is poor nutrition with pregnant women. And right now we're working with a nutrition group to try to document primarily working from economic impact to food insecurity to then lower consumption of micronutrients. So there is some impact of stillbirths in the country-specific models. We just didn't publish those in the overall paper.
Thank you, Nev. And there's one more question regarding HIV/AIDS services included in the analysis.
We did not do that. It's quite easy if you, within the models, actually, if you look at our models, LiST is built within the Spectrum software, which includes an AIM module. And it's quite easy to go in and change coverage of primarily ARTs, because that's what we use for PMT-CT, and ART coverage for children. We didn't do that, I think in part because at that point, there hadn't really been much thinking about was it going to affect incidence of HIV. I think the most recent news I've heard is they've decided it will probably be a wash, that there will be less prevention services which would have a tendency to increase incidence, but then social distancing and stay-in-place orders would probably reduce incidence. So they think incidence won't change, but in fact, in the model, you can go into the AIM module and change coverage of ARTs, both for adults in PMT-CT and ART for treatment for children, but we did not include that in these models.
Thank you, Nev. Yeah, and on the stillbirths, just want to add that the UN Interagency Group for Child Mortality Estimation is producing its first set of estimates on stillbirths, and we are now discussing with Nev and the LiST team how we can really look into the impact on stillbirths due to the COVID-19, and maybe do some similar modeling work, or if real data is available, then we can also do country-specific modeling work. So that's something from our side I want to mention. Anybody wanted to jump in to ask questions? I haven't seen any hand raised.
If not, we had a few questions earlier that we didn't address. So if you want me to raise them.
Yes, Lucia, please.
There was a question whether from Bill from USAID, whether we would use the Google mobility reports by country to get a sense of reduced utilization of services. That was a suggestion. And then there was also the World Vision report mentioned that modeled the secondary impacts of COVID-19 on health and nutrition.
Can I help to respond a little bit to that, Danson?
Yeah, sure.
So for the World Vision report, I would ask for the details of the modeling. When I looked at the paper, I didn't see the actual details. I know it was based on assumptions of the Ebola, but it looked very simplistic to me, and I would need to have more details on that. So World Vision would have to answer that. In regards to all the different, there are tons of pulse surveys. There's tons of surveys out there right now. And we need to work together, WHO, UNICEF, UNFPA, to try to bring all those together. But each country has to kind of do the same thing as well. Because what do you do when you get different reporting about the same type of disruption of services? And one says no, another says yes. There's just so much collection of data now that we really need to try to harness this and bring this together to get a better sense of what's going on.
Mm-hmm. Okay, great. Thank you, Teresa. Lucia, is there any questions that we haven't addressed from the chat box?
There was one question earlier about the use of family planning, the reduced CPR and increased TFR, but that will be a question to Neff and his team.
Yes. So we did a fairly simplistic approach on family planning in terms of reducing CPR, but because we're not doing because most of our projections are 3 months, 6 months, and then we had 1 12-month, there's not a huge effect. Also, we knew when we did our adjustments on CPR, we did this about 5 weeks ago. They were fairly simplistic in that people that are using long-term methods. So we kind of did a gross reduction in CPR, but in fact, it should be weighted by method type. And so right now we've been working with Avenir Health on doing kind of more refined assumptions about CPR, just given that lots of the long-term effects, IUDs, for example, even though the 3-year period may expire, they'll still be effective for are fairly effective up to another year, so that we didn't push that very hard because we'd known we had done a fairly simplistic approach, not considering country-specific method mix in our analysis. But we're going back, the idea now is we're trying to create a new set of country-specific estimates that include the changes to HIV and the more nuanced approach to contraceptive prevalence rate, and finally the improved ideas of economic impact on food security and diet, which is all kind of round 2 that we're in the middle of at this point.
Thank you, Neff. Before we closing, just want to ask maybe like whether participants, colleagues have any additional questions. Please jump in if you have. Okay, sounds all clear. So thank you for your participation, and we will share all the slide presentations through the web link that I or Lucia already shared in the chat box. And also, please feel free to reach out to either Teresa or me or Lucia Dave if you have any additional questions or would like to do any country-specific modeling work, and as Teresa already said, that the consortium and also the subgroup under this consortium, one group is on modeling, and we are really coordinating the modeling work, try to summarize the pros and cons of each model. And when we have some more results, we'll also share that, and also probably we'll have more webinars on that. We'll make everything available, so please check the website that we just shared. Teresa, do you want to say a few words before we
So,
close?
as you have already said that you're sharing the different PowerPoints, and we also, as part of those PowerPoints, you can actually see the guidance of what to do to try to maintain these essential services as well. And you will see from the PowerPoint the links to WHO where you can find that different information. Thank you.
Thank you very much. Thank you, Nev, and also to Tim and Emily as well for great presentations. And we'll keep in touch. And the colleagues also feel free to reach out to us and the LiST team as well if needed. And we are happy to support and facilitate. So we'll close the webinar today, and we'll be in touch soon regarding the future work. Thank you all, and have a good day or good evening.
Thank you.
Thank you.